So, hello, I'm Dr. Louise Newson. I'm a GP and menopause specialist in the UK, and I also have an immunology degree, and my background is hospital medicine. So, I'm very interested in the role of female hormones on health. So, as all of you know, there are sex differences with COVID infection, and men, right from the start, have had a higher risk of more severe disease than women, and also are more likely to die from COVID infections than women. And all I do as a physician is menopause work. I run probably the busiest menopause clinic, maybe in the world, but certainly in the UK. We see over 1,000 women a month in my clinic. I have 24 GPs working with me. And so ever since the COVID outbreak started, I've always been thinking, are hormones related in some way? There was an early study that came out of Wuhan, which showed that women with low estradiol levels actually had a more severe infection. And this is something that really sparked my interest quite early on with the COVID outbreak. So we've known for decades that we have estrogen receptors on all our cells in our bodies, but especially our white cells. And estrogen is very important when it comes to infections and immunity. As women, we have a better adaptive and immune response than men. And for many of us who have sort of poo-pooed the whole man flu in the past, actually might be wrong. It might be that because men's immune system is weaker, they are less able to fight infections in the same way that women can. And as I've said, we have estrogen receptors on every single immune cell. And when the estrogen or the estradiol um, when it actually goes onto the receptors, it can modulate the way these cells work. It can change the way they differentiate. It can genetically reprogram them and change the lifespan and also change the way that they work, which is really important. Really, what's probably quite pivotal, I think, with respect to COVID is that estradiol can regulate the production of numerous cytokines, including the ones that are really key, we think, for COVID, so interleukin 6, tumor necrosis factor, and interferon. So this is quite a busy slide, but it was one that I found that showed you how estrogen is pivotal in every immune cell. So I don't need to talk through it, but you can see it affects the T cells, it affects natural killer cells, dendritic cells, our B cells, monocytes, neutrophils. And it's really important to think about estradiol because estradiol is the main estrogen that's produced before the menopause. And when women become older and menopausal, they still have a bit of estrogen in their body, especially if they're overweight, because fat cells produce a very weak type of estrogen called estrone. But that's actually pro-inflammatory, and it has a low-grade inflammatory effect, especially on macrophages. So it actually is very negative for immune system. And we know that people who are obese are more likely to have severe COVID. So we can't get confused here with estradiol, which is in premenopausal women, and also in transdermal estrogen that I prescribe a lot of in HRT, very different to estrogen that's in fat cells, and also oral estrogen, which is in some of the older types of HRT preparations. So we know that the ACE activity, angiotensin converting enzyme, is very important with respect to COVID. And we know that estradiol actually works to downregulate angiotensin 2 receptor type 1 signaling pathway. It also can inhibit ACE activity, and it has a positive effect on the expression of the ACE2 protein. What's really interesting for me as a menopause specialist is that we have a lot of ACE2 receptors on our ovaries. Clearly, they're all over our body, but there is this thought that if it's attacking, the COVID infection is attacking the ACE2 receptors, then ovarian function is probably going to be affected more than it would do if it was just another infection. So what about the protective effects of estradiol? Well, it's been really hard to get data. I've been working very hard with various teams in the UK to tease out the data, and it's been very difficult because there are so many confounding variables. But this is a study that came out fairly recently from a team in Berlin, also working with a team in Italy and also America. And this was using data from nearly 70,000 patients who had tested positive with COVID. It was across 17 countries. And they found quite clearly in their data that women over 50 who were taking HRT were more than 50% less likely to die from COVID infection. And the odds ratio and the hazard ratio, as you can see, were favourable. And certainly, speaking to the team there, the data was peer reviewed, and they're very convinced that this is something, a signal that really needs to be looked at in more detail. And anecdotally, speaking to some ITU consultants in London, but also in New York, they've been very stricken by how few women on HRT have actually gone to intensive care. Certainly in Stony Brook Hospital, they haven't had one woman taking HRT who's gone to intensive care. So then going further, thinking about acute infection, how important that is, and we're just about to start a study actually in Qatar, India and Iran, looking at giving transdermal estradiol gel to men and women who have been tested positive for COVID to stop them going into ITU and hopefully reduce mortality. And that hopefully will be by reducing the cytokine storm. So we'll hopefully get some results with that. But now thinking about long COVID, and I'm sure a lot of you have heard about long COVID, and it's certainly something that's here to stay. We don't know how common it is because a lot of women and men who are presenting haven't actually been tested positive with COVID because they had the infection several months ago before testing was routinely done. So around 1 in 5 people have symptoms of long COVID, and these are symptoms which persist after 5 weeks. And 1 in 10, so a really high proportion of people who've had a COVID infection are still having symptoms 12 weeks or longer. So a considerable portion of people with long COVID do have complications, and obviously we don't know what the full ramification is and what the complications are going to be in the longer term. But the symptoms are very varied, and they suggest a multi-system disorder, which is what you would expect the way that the COVID infection affects people. So a lot of the symptoms include symptoms such as brain fog, headaches, dizziness, reduced stamina, poor fatigue, fevers, shortness of breath. So again, thinking about hormones, do they have a role in long COVID? I don't think it's the only picture, but I think it's something we need to really explore and consider in women and possibly even in men as well. So we know there's a big group of people with long COVID who are women in their early 50s. And I don't think it's a coincidence that the average age of the menopause in women is 51. Now, there are various reasons why this can happen. And firstly, that any infection can have a direct negative effect on ovarian function. But also, we've already mentioned the way there are ACE2 receptors in the ovaries, so it might trigger ovaries failing quicker than they would have done just with another type of infection. But also, since March, when COVID really came over into the UK until now, so over 9 months, there will be a lot of women who will have naturally become either menopausal or perimenopausal. And these women are maybe thinking they've got long COVID, whereas actually they are perimenopausal or menopausal. So if you think, for example, a lot of women are misdiagnosed with fibromyalgia, chronic fatigue, even depression. And actually, when we see them in our clinic, we give them the right dose and type of HRT for them, and they completely improve. So they haven't got fibromyalgia or chronic fatigue. So obviously I'm thinking, well, is there something else? Maybe they're not even got long COVID, but there's no one else diagnosing them, these women, properly. So I sent a questionnaire out just through social media, and we've had a significant response. We've had a response of around 700 people. And we just asked some very simple questions. So this isn't proper research, but it's getting a feel because there's a lot of mutterings about people who have noticed their periods have stopped or changed since having the diagnosis of long COVID. And you'll see in blue here the biggest bar is showing that periods change in frequency or nature. Then most of them say yes. And then I asked, do their long COVID symptoms vary during their cycle? And again, The majority, just over half, have said yes, and about a quarter said there was a variable. So there's something going on with hormones, because if periods change, hormones are changing as well. And then this is another very interesting question, I think. So which time of your cycle are your long COVID symptoms worse? And you'll see that the vast majority are either just before their period starts or during their period. And as many of you, I'm sure, know, this is when estradiol levels are at their lowest. And they classically are very low just before periods. And that's why, of course, so many women experience PMS or premenstrual syndrome, because their bodies, especially their brains, are reacting, if you like, to the low hormone levels. And I'm sure there's some association with worsening long COVID symptoms with estradiol levels being low. So if we think about the perimenopause and menopause, clearly the menopause affects all women, and I'm sorry to exclude men in this presentation, but we are 51% of the global population, so we can't be ignored. And the menopause needs to be thought of as a long-term hormone deficiency. It's not just something that causes symptoms for a few women who just need a fan. It's actually, without these hormones, there are health risks. And we know that women who don't have hormones, who are menopausal, have an increased risk of cardiovascular disease, type 2 diabetes, osteoporosis, obesity, depression, and dementia. And when you think about COVID, actually, thinking about cardiovascular disease, diabetes, obesity increasing, that's really key, because these factors, as you know, increase mortality from COVID. And so women now live for decades being menopausal. 100 years ago, we used to die quite soon after our menopause, but we are living decades. So it's really important that the health risks of the menopause are addressed, regardless of whether a woman has COVID or not. We have really clear menopause guidelines, which sadly aren't being adhered to either in the UK or worldwide. Poor menopause care is a global health problem. So we've got the NICE, the National Institute of Health and Care Excellence Guidelines in the UK, and the IMS, the International Menopause Society Guidelines. And they're very similar in what they say. And firstly, obviously, like with anything in medicine, that the patient should receive individualized care and treatment. But really key is that the benefits of taking HRT outweigh any risks for the majority of women. Yet globally, the vast minority of women take HRT. So that means they're denied a treatment that not only improves their symptoms, but also reduces their future risk of these conditions I've mentioned. Everyone is worried about the potential risks of HRT and breast cancer, but we know from following up WHI study for 18 years that women who take estrogen only HRT, so women who've had a hysterectomy, actually have around a 25% lower risk of breast cancer. This small risk of breast cancer is associated with synthetic progestogens, which actually I don't even use in my practice. We use a body identical progesterone. So we also know reassuringly that even when people take combined HRT with synthetic progestogens, the all-cause mortality from all causes, including cancer, actually is reduced in women who take HRT in the long term. And more significantly, really, when thinking about COVID, is that women taking HRT have a lower future risk of cardiovascular disease, type 2 diabetes, and obesity. And so ways of reducing our future risk of COVID is a way, it's got to be thinking about HRT, because future health will be better. And this is really not being addressed. We know that the minority of menopausal women still take HRT. And there was a study recently that came out in the British Journal of General Practice showing that women from low socioeconomic classes are 29% less likely to be given HRT. And as I'm sure you know, most of these women have an increased risk of cardiovascular disease, obesity, and diabetes. So they will have more to benefit actually from taking HRT. We know, I've already said, there's estrogen receptors on all our cells in our body. So if you break down and think about how estrogen works, then it's easy to think about the lack of estrogen, how it has a detrimental effect to many women, thinking about symptoms as well as health risks. This is just a picture that we created when I did some work with West Midlands Police in Birmingham, and it shows the myriad of symptoms that people can experience during the menopause. It's far more than just some hot flushes. So then thinking estrogen, I've mentioned, is a really important hormone for women, but actually as women we produce testosterone as well, and interestingly we produce more testosterone before the menopause than estrogen, and testosterone levels decline with age, whether it's an age-related decline or a menopause-related decline. We're not actually sure, but needless to say our testosterone levels decline. And it's thought about between 9 and 15% of menopausal women experience HSDD, which is hypoactive sexual desire disorder, and it's associated with low testosterone. It's not just about libido and sexual pleasure that reduces, it's actually their well-being, their mood, their reduced motivation, this persistent unexplained fatigue, reduced muscle strength, low stamina, cognition, memory problems. And I'm mentioning all this because if you remember me saying earlier, symptoms of long COVID are very similar to these symptoms as well. So thinking about long COVID treatment, we don't know, it's too early to have an effective treatment. The most important thing is getting the diagnosis right. And I certainly feel very strongly that women need to have their perimenopause or menopause excluded before they are just given the diagnosis of long COVID. So many women I speak to and women that I see and help in my clinic have been told they've got long COVID, but they're also menopausal or perimenopausal. I give them a symptom questionnaire, menopause symptom questionnaire, and they're filling out it. And I know their periods have changed, so therefore they're perimenopausal, but no one's giving them a diagnosis, no one's offering them treatment. So out there, there's a lot of social media networks for people with long COVID, and a lot of them are helping each other, which is not always the best way to be because there's nothing, no one's being leading by evidence. Just to let you know, I've produced an app called Balance, which is a free app that can be downloaded from the App Store or Google Play. And on it is a menopause symptom questionnaire. And if women fill them out, they can fill out their periods as well, then it will generate a health report. And what I'm really asking people to consider is for the women with potential long COVID, is to download the free app, put in their symptoms, create a menopause symptom score, and take this and create this health report, and then take it to their doctor, and then have their perimenopause or menopause addressed before just being simply referred to a long COVID clinic where no one really knows how to manage them. We've got guidelines in the UK. The scoping document has been produced, and it's a combination with NICE-SIGN and the Royal College of GPs, and they're very much focusing on self-management, psychological support and rehabilitation. But we don't know what the best treatment is. But there's certainly no mention of hormones, and I don't know whether hormones would actually help with COVID, or whether it's just the fact that these women, a lot of them are perimenopausal or menopausal, and they need hormones anyway. But actually, HRT is very safe, it's very cost effective. So women need to be offered it if they are going to have more benefits than risks with HRT, which I've already said is the vast majority of women. Anecdotally, we've seen a lot of women in my clinic who have been diagnosed with long COVID. And estrogen has certainly helped, but testosterone has made a huge difference for these women. Their brain fog, their stamina, their muscle weakness, their fatigue has really been transformational. And I've personally seen some women who have been bedbound, and they've then managed to walk up the stairs, they've managed to help. And I'm not saying that hormones are the only answer for long COVID, but if they improve people even by 20, 30%, for a lot of these women, it means they can look after their families or they can go back to work, which is really life-changing for a lot of them. So finally, where do we go from here? Well, certainly I've already said, and I really want to address that all women, regardless of their age, because young women can become menopausal and perimenopausal too, if any woman is being referred or considered to be referred to a long COVID clinic, they need to be assessed. Are they perimenopausal or menopausal? You can't do a blood test for the menopause or perimenopause. It's on symptoms, but use the app. reduce your clinical load and ask them to download it before they come to you in your consultation, and they can give you the health report, which will tell you whether they're menopausal or not. And then if they are a candidate for HRT, give them the appropriate HRT, because they need that anyway, whether they've got long COVID or not. Having estrogen through the skin as a patch, gel or spray has no risk of clot. Having micronized progesterone has no risk of clot or heart disease. So very, very safe. And certainly I'm not a researcher, I'm a physician. But we really need to have more research in this area. And there's a lot of interest in the UK, even with our government having research, but it's finding the right team and network to work with. So if any of you can help, then just please contact me, and we can see where we can go from here. But I certainly think it could be quite game changing for a lot of people if they have their hormones addressed. So thank you for listening.